There is a thing that is supposed to happen to your blood pressure every single night while you sleep. Somewhere in the deeper stages of sleep, your blood pressure is supposed to fall. Not crash, not drop dangerously, just dip 10 to 20% below your daytime average in a predictable, protective pattern your body has been running every night of your life. This dip has a name. Doctors call it nocturnal dipping. And when it happens the way it should, it is one of the most quietly important things your body does for your legs. But for a significant number of people over 60, that dip does not happen. Or it happens only partially. Blood pressure stays elevated through the night, hour after hour, when it is supposed to be falling. Doctors have a name for that too, non-dipping. And research has found that in one large study of elderly adults, more than a quarter of people with completely normal nighttime blood pressure patterns lost that pattern within just 2 years, shifting from healthy dippers to non-dippers, often with no symptoms they would ever think to mention to a doctor. I am Dr. Mary, and today I am going to show you the connection between your bad sleep and your leg cramps, a connection that has a real name, real research behind it, and a real reason it has been hiding in plain sight. Your autonomic nervous system runs on a balance between two branches, and as I covered in the last video, the vagus nerve carries most of your parasympathetic. Rest and restore signaling throughout your body, including the vessels in your legs. Nocturnal dipping is one of the clearest expressions of that balance working correctly. When you fall into deep sleep, your parasympathetic system should take over. Vagal tone should rise, your heart rate should slow, and your blood pressure should fall, because your body, correctly reading that you are at rest, no longer needs the elevated pressure that daytime activity requires. Non-dipping is what happens when that handoff fails. Your body stays in a more sympathetically driven state through the night, closer to its daytime baseline, even though you are asleep. Stay with me, because the reason this matters specifically for your legs is not obvious, and almost nobody explains it. I want to tell you about a man I will call Walter. Walter was 71. He had well-controlled hypertension on a single medication. He did not have diabetes. He did not have a complicated medical history. By every measure his primary care doctor used, Walter was doing well. But Walter's legs told a different story at night. Restlessness that started almost exactly when he fell asleep, not before. Not during the day. Specifically once he crossed into deeper sleep. A heaviness and a dull ache in his calves by 3 or 4 in the morning that sometimes woke him fully. And in the mornings, despite 8 hours in bed, his legs felt as though he had not rested them at all. He had tried everything a typical leg symptoms approach would suggest. Stretching before bed, compression socks, magnesium, elevating his legs. Each helped marginally. None resolved it. Nobody had ever measured what his blood pressure was doing while he slept. When Walter finally underwent 24-hour ambulatory blood pressure, monitoring a test that tracks blood pressure continuously through a full day and night, including sleep, the pattern was clear. His daytime blood pressure was well controlled, exactly as his home readings and office visits had always shown. But overnight, his blood pressure fell by only about 6% from his daytime average. The threshold for healthy dipping is a fall of at least 10%. Walter was a non-dipper. And nobody had ever looked. Because nobody ever does a standard blood pressure check at a daytime appointment cannot see what happens to your blood pressure at 3 in the morning. Here is why this matters so specifically for your legs. During healthy nocturnal dipping, the fall in blood pressure is accompanied by a corresponding shift in your peripheral circulation. As your sympathetic tone decreases and your parasympathetic tone rises, your peripheral blood vessels, including the ones in your legs, undergo their own nightly pattern of relaxation and restoration. Vascular resistance decreases. Blood flow to your tissues, including the muscles and nerves in your legs, has its best opportunity of the entire 24-hour cycle to recover and repair. This is, in a very real sense, when your legs are supposed to get their nightly maintenance. When you are a non-dipper, that maintenance window is shortened or lost. Your peripheral vasculature stays in a more constricted, sympathetically driven state through hours when it should be relaxed and restorative. Blood flow to your legs during sleep, when you would expect it to be at its calmest and most efficient, instead continues operating closer to its more constricted daytime pattern. Research examining the autonomic nervous system in elderly dipper and non-dipper patients found that non-dippers show a measurable impairment in autonomic nervous drive, specifically a decrease in parasympathetic activity compared to dippers of the same age. The blunted nocturnal blood pressure fall and the reduced vagal tone are not two separate findings. They are the same underlying problem observed from two different angles. This connects directly to what we covered in the last video. Reduced vagal tone after 60 contributes to non-dipping. Non-dipping means your legs lose their nightly restorative circulation window, and legs that do not get that window night after night, year after year, are legs that feel restless, heavy, and undernourished by morning for reasons that have nothing to do with what you ate, what medication you take, or how much you stretched before bed. Stay with me, because there is a second piece of this that explains why so many non-dippers do not know they are non-dippers, and why this almost never gets caught. Here is the problem with non-dipping as a clinical finding. It is invisible to almost every standard way blood pressure gets measured. Your blood pressure at a doctor's office appointment is a single daytime snapshot. Your home blood pressure monitor, if you use one, almost certainly measures during waking hours. Neither of these can tell you anything about what happens to your blood pressure between midnight and 5 a.m. The only way to actually detect non-dipping is 24-hour ambulatory blood pressure, monitoring a portable cuff worn for a full day and night that takes readings automatically every 20 to 30 minutes, including through sleep. This test exists. It is validated. It is the recognized gold standard for assessing nocturnal blood pressure patterns. And it is rarely ordered for someone whose daytime blood pressure looks well controlled, because daytime control is what most appointments are designed to check. This is why Walter's doctor had no reason to suspect a problem. Every reading Walter had ever given him looked normal. The non-dipping pattern was operating entirely outside the window his doctor was checking. Research has also found that non-dipping is strongly associated with orthostatic hypotension, the dizziness some people feel when standing up quickly, and with reduced heart rate variability, the same HRV metric we discussed in the last video. If you have ever stood up too quickly and felt the room tilt for a moment, that dizziness may be a daytime signal of the same autonomic pattern showing up differently at night. And if your HRV trend has been declining, that is a second signal pointing in the same direction. Combined with restless or heavy legs at night, these are three windows into one underlying autonomic pattern. And this is exactly where Walter's story picks back up, because once his doctor knew what to look for, the picture became unmistakable. Once Walter's non-dipping pattern was identified, his cardiologist had several evidence-supported options to discuss, none of which involved adding new medications for his legs specifically. The first and most well-studied approach is chronotherapy, adjusting the timing of existing blood pressure medication rather than the medication itself. A randomized controlled trial published in JAMA Network Open in 2025, the OMEN trial, conducted across multiple centers, found that switching combination blood pressure medication from morning to bedtime dosing significantly improved nocturnal blood pressure control. In the bedtime dosing group, the proportion of patients with a non-dipper or reverse dipper pattern dropped from 57.9% to 5% over 12 weeks. In the morning dosing group, there was no significant improvement. This is not a universal recommendation. The right timing depends on the specific medication, your full health picture, and your doctor's judgment. But it is a real evidence-supported, low-risk conversation to have if you are a documented non-dipper. The second approach circles back directly to what we covered last week, supporting vagal tone through diet, slow breathing, and consistent movement supports the parasympathetic activity that drives healthy nocturnal dipping. The practices that help your gut and your daytime circulation are the same practices that support the nighttime autonomic shift your legs depend on. Walter's cardiologist moved his blood pressure medication to evening dosing, and Walter incorporated the slow breathing practice we discussed last week, 5 minutes before bed. On a follow-up ambulatory monitor 3 months later, his nocturnal dip had improved from 6% to just over 11% into the range considered a healthy dipping pattern. His nighttime leg restlessness reduced significantly within the first month. By 3 months, the heaviness that used to wake him at 3 or 4 in the morning was largely gone. He still occasionally noticed it on poor sleep nights, but the nightly pattern that had defined his last several years had genuinely changed. Here is what you can take from Walter's experience. If your legs feel restless, heavy, or undernourished specifically during sleep, different from how they feel during the day, and not explained by anything in this series so far, ask your doctor specifically about 24-hour ambulatory blood pressure monitoring. Say, I would like to ask about getting a 24-hour ambulatory blood pressure monitor to check whether I have a normal nocturnal dipping pattern. This is a specific, named test, and naming it by name is what gets it ordered. If you already take blood pressure medication, ask whether the timing of your dose has ever been reviewed in light of nocturnal blood pressure patterns specifically. This is not about taking more medication. It is about when you take the medication you already have. Tomorrow morning, write down one observation. Do your legs feel different, worse, more restless, less rested specifically after sleep compared to how they feel during the day? If the answer is yes, that pattern is exactly what a nocturnal blood pressure conversation is built to investigate. 3 things to carry with you. 1. Nocturnal blood pressure dipping is the healthy 10 to 20% fall in blood pressure that should happen during deep sleep. Non-dipping when that fall does not happen is common in older adults, frequently undetected, and directly connected to the parasympathetic and vagal tone changes we discussed in the previous video. 2. Non-dipping shortens or eliminates the nightly window when your peripheral circulation is supposed to relax and restore. Legs deprived of that restorative window, night after night, often feel restless, heavy, and undernourished by morning for reasons that standard daytime blood pressure checks cannot detect. 3. The only way to actually find out is 24-hour ambulatory blood pressure monitoring, a specific, named, validated test that is rarely ordered unless you ask for it directly. If your legs feel distinctly different during and after sleep, that test is the conversation to start. This video completes something I want to acknowledge directly. Across this series, we have moved from medications and their depletions to the body's own regulatory systems, the vagus nerve, and now the nighttime blood pressure pattern that nerve helps to govern. Different mechanisms. Same underlying truth, your legs have been trying to tell you something through channels most appointments are not designed to hear. Next week, we go inside the single stage of sleep your legs need most, and what quietly disrupts it for so many people over 60, in a way that has nothing to do with insomnia or sleep apnea. Subscribe so you do not miss it. And if this video gave you a new question to ask at your next appointment, that is exactly what it was built to do. Take care of those legs. I will see you in the next one.